I'm going to be talking about just basics about hormones and hormone replacement therapy, because I've had so many questions today, so thank you for asking me. But all the time on my Instagram, when I see people in the clinic, when we are just talking to people, they're always asking about HRT. So I know I've talked about it before, and I'm sure I'll talk about it again, but I thought I would just come back to some very basic information. HRT is 3 letters, but it's caused the most amount of discussion, uncertainty, people not really sure what it is. So I just thought I'd just make it really simple for you, and hopefully you'll find it really helpful. HRT stands for hormone replacement therapy. Now, I don't actually really like the term HRT because firstly it says hormone. Now, we've got hundreds of hormones in our body, so it's not actually telling us what hormones they are. But it also makes it sound like it's one hormone because it's hormone replacement. So then if I didn't know, I sometimes think if I was an alien from outer space coming to listen and learn about hormones, I would be so confused. So it's not telling us whether it's one hormone, more than one hormones, what hormone it is in fact. And then the R is for replacement. So we actually don't always replace hormones. What we sometimes and often do actually is give back the missing hormones. And it's a bit nuanced, but it is different because, as you know, in menopause, hormone levels are low and stay low forever unless we give them back. So we are then replacing missing hormones. But in perimenopause, hormone levels fluctuate a lot and they can become very, very high and very low within a matter of sometimes minutes or seconds even, or days or months, depending on the person. And so we're not always replacing their missing hormones. We had someone in the clinic the other day, and we often do baseline blood tests, and I'll talk more about blood tests later. But she came and she was perimenopausal, so she was having myriad of symptoms. Her periods were fairly regular, so she had her hormone blood test done, and her estradiol level was really raised. It was 2,270. Now, when we give back hormones, we usually aim for a level of estradiol to be between 250 and 1,000. 2,270 is really high. We wouldn't give people to replace to that amount, but her body was producing that amount at the time the blood test was taken. So during perimenopause, we wouldn't be replacing those hormones to the way that her body was. And then when we give hormones to women with PMDD, premenstrual dysphoric disorder, or PMS, premenstrual syndrome, then we often just top up the hormones that are low on parts of the cycle. And for some women, it might only be a few days every month. And so we are sort of topping up really rather than replacing. And then the T part of hormone replacement therapy, the T is for therapy. Now, I know I'm a clinician, and I give lots of treatment to lots of people for all sorts of different conditions, and I have done for the last 30 years as being a doctor. But therapy sounds like you need a couch and it's a bit of a talking treatment. So I just feel there's a lot more that we could do to change the terminology. In some countries they call it MHT, menopause hormone treatment. But again, I don't think that really describes the full picture, because we give hormones to women who are not menopausal, if they're perimenopausal, if they've got PMDD or PMS, like I've just said, we still give hormones to those women. So then you're sort of excluding those women if you use the word menopause. And then it's still hormone. It's still one singular hormone, and it doesn't say what it is. And then treatment is probably the best part, because it is a treatment, but it is actually just a natural treatment. So when I talk about hormone replacement therapy, or HRT, or hormone treatment, I think is probably a better term, I'm really thinking about 3 hormones. Estradiol, which is the very nice anti-inflammatory type of estrogen, because there are lots of different types of estrogen. Progesterone, the natural progesterone, and testosterone, the natural testosterone. And it's important because there are lots of different types of HRT, and many of them that have been given for decades are synthetic, so they've been chemically altered. So they actually don't convert to estradiol, they convert mainly to estrone, which is a very inflammatory type of estrone and has been linked with types of cancers. But that's not the same as estradiol, which is anti-inflammatory. So as we get older, as we become menopausal, if we don't give estradiol back in our body, especially our fat cells, our adipocytes, produce estrone. It's a weaker type of estrogen, but it's all the body can do if it needs it. And it's very inflammatory, like a lot of the chemicals that our adipocytes, our fat cells produce. It produces a whole lot. Our fat cells are very metabolically active, but they produce all sorts of chemicals, but including estrone, which is very inflammatory. So when we give estrogen now, we give estradiol, the anti-inflammatory type of estrogen. But in the past, it was tablet estrogen which converted to estrone, the inflammatory type. So when we're talking about risks and benefits and side effects, you have to be really clear. Is this about the natural hormone, or is this about synthetic hormones, or about estrone? And that's the same when we think about progesterone as well, because now we give the natural progesterone, whereas in the past it's synthetic progesterone which has been chemically altered, which is in the older types of HRT and actually in contraception as well. And for those of you that are coming to my tour, which starts on Friday, I'm going to be going into this in quite a lot of detail. And over the next few weeks and months, and probably years, I will be talking more and more about the difference between natural and synthetic hormones, because this is really crucially important that women know who are taking these hormones, but also healthcare professionals like me really understand the difference, because when there is any academic debate about risks, benefits, side effects, we have to be clear what we're debating, because you have to be thinking about the same hormones. If we think about the WHI, the Women's Health Initiative study that came out in 2002, when they showed this risk with breast cancer, this was with synthetic hormones. So the type of HRT women were taking, as many of you probably know, the estrogen was made from pregnant horses' urine. It contained a plethora of estrogens. So not just estrone, it had a very small, about 5% of estradiol, but lots of other estrogens that I cannot tell you that they have any beneficial effect in the human body. They were there in the horses, but not in humans. And then the type of progestogen that they gave was a synthetic progestogen called medroxyprogesterone acetate. Very, very different to the natural progesterone that we produce, that we prescribe now. But the other thing is that in the study, they gave the estrogen as a tablet, so it was metabolized through the liver. But the results showed the breast cancer risk was only in the combination, the estrogen and progestogen, the synthetic progestogen, not the estrogen only. And as you see, if you look at my post today, which was a great debate, a great discussion with two doctors on Peter Attia's The Drive podcast, saying that there wasn't an increased incidence of breast cancer death, which again is really important for people to know. And so they talk a bit about the awfulness actually of the WHI study, making everyone scared of hormones, which still happens today. We see women in our clinic because they have been failed by the NHS, because they have been told they can't have hormones or they're not on the right dose or type. So they actively seek us out because they want some advice from people who are specialists in hormonal treatment. But also in our clinic, most of us are GPs, general practitioners or family physicians. A lot of us have got a hugely extensive background of dealing and managing women with a huge number of conditions as well. So we're used to looking at the bigger picture, which is really important when you think about how our hormones work in every single cell in our body and every single organ and tissue in our body. So we're not just thinking about the womb and periods, we're thinking beyond that, and especially our brain. And I've spoken a lot about the brain and the role of hormones in our brain, which is so very important. Now, some people have said, well, how do you know whether I need HRT? What do you do when we start? Do you do a blood test when you start? How do you know the dose? Well, medicine is a science, but it's an art as well. And so actually the art of medicine is individualising care. which is really crucially important. And so when we decide about starting hormones, it depends on many factors. It depends on symptoms, it depends on the age of the woman, it depends whether she has any other medical history that's relevant. It also depends whether she's perimenopausal or menopausal. And so all of those things can determine what dose we start. Now, in our clinic, we often do a blood test before starting hormones, and certainly offer it. It's very much up to a patient what they do. And the reason for that is more to have a baseline blood test, making sure that all other indices in the blood are normal. So making sure someone's not got an underactive thyroid gland, or they've got low vitamin D or low iron that could be causing tiredness and low mood and sort of apathy or anhedonia or whatever. And so a lot of women are very keen to have their baseline blood tests. Also, we do like cholesterol blood test as well, and people quite often want to see how their blood cholesterol goes down when they're taking hormone treatment. If we're starting testosterone, I'll talk about testosterone in a little bit, then testosterone, we actually usually do a blood test before, because we want to see that it's low, and then we've got something to benchmark it as people take their hormone treatment. Estradiol levels can be useful, but if someone is menopausal or postmenopausal, so when I say menopausal, I usually mean postmenopausal as well, because you're always going to be menopausal until the day we die, but hormone levels will be low. So it's not always useful to do the blood test just to know that it's low. And if someone's perimenopausal, like I've explained, you might have a high level of estrogen because the body's fluctuating all the time. So I wouldn't want to use a hormone blood test to make an absolute diagnosis. And the other thing is, even if the estradiol testosterone levels are both low and someone's tired, it doesn't mean that tiredness is caused by the low hormone levels. There are other reasons. So we need to be really open-minded when we see people and make sure there's nothing else going on that we need to exclude or treat, depending on the scenario. So we usually start at a moderate dose of estrogen, and we give the estrogen as the estradiol because it's so much better. Metabolically, biologically, it works throughout the body on the estradiol receptors in a natural way. And so we give it through the skin as a patch or a gel. Now, when we give it through the skin, all we're doing is using the skin as a vehicle. So the estrogen is applied to the skin, and it goes through the skin into the bloodstream. Now you can imagine all our skin types are different, of course they are. So it depends on the skin temperature, the thickness, the fat that's under the skin, the blood supply through the skin as well. And it also depends on location. So what works for one person might not work for the other, just because they're not absorbing in the same way. And so when we decide whether to give a patch or gel, it's usually a personal preference. Some people like the convenience of having a patch that they stick on and change twice a week. Other people prefer rubbing something into their skin every day. Often when people are starting and they're older and they might not have had HRT before and they're in their 60s or 70s, I often advise them to maybe start with the gel, because then they can see the volume they're using and start with a very, very low dose and then increase it depending on how they are, with medical review, of course. So I'm sure a lot of you have seen the gel before. I'm just going to put a bit on my hands so you can see what it looks like. But it's just a clear gel. Hopefully you can see in the light, it's just a clear gel that gets rubbed onto the skin. So usually on the outer part of the arm and the inside part of the thighs. Now the skin is pretty much similar everywhere. So some people have said, oh, can I not rub it on the inside of my arms because it's too close to the breast? Well, actually, it just is going into the bloodstream. So the bloodstream goes all around the body anyway. So it doesn't matter as long as it's rubbed in. Once you've rubbed it in, then use any excess. Some people wipe the excess down their legs if they've rubbed it on their arms, and then wash your hands thoroughly. Some people have been scared about what if I touch my children or touch somebody else. But we have to remember the dose is very, very low of estrogen. And if your skin is nice and dry, then you're not going to have any on your skin anyway. You will wash it off. Now, if you think equivalently to the contraception, contraceptives contain, I've already said, synthetic hormones, but the equivalent dose is incredibly higher. It's a lot higher than using like 1 pump of gel or even 4 pumps of gel. The dose is still a lot lower in HRT, just to reassure you. So the dose is very low. Men have estrogen as well, actually. So, but obviously wash your hands. Once you've applied it, then just wait for the skin to dry, and it really varies between people. Some people say that it literally floats off their skin, and even when they rub it, it doesn't get absorbed. If that's the case, then the gel might not be for you. There is a gel in a sachet which we sometimes use, which is a bit thicker and more viscous. So one type of gel might not work, and then we might change to another. So it's about choice is really important. There are many different makes of patches. Unfortunately, in my clinical experience, a lot of the patches don't stick on very well. So there's only a couple of manufacturers that I'll use with more confidence. But the patches come with a backing that you just take off. And if I just show you on the screen, it's just a clear plaster. So any skin type or colour, it should be completely transparent. So it doesn't matter, it's not a coloured patch. It doesn't go on the back of the hand. It usually goes below the waist, so on the lower back, on the bottom, on the thigh. Anywhere that sticks is really important. Now the glue is where the estradiol is. So the more it sticks, the better the absorption is going to be. But sometimes the patches can crinkle, so make sure the skin is really nice and clean and dry before using it. Some people even use like an alcohol wipe, let it dry to the air and then put it on. Whatever works for you is really, really important. The patches usually change twice a week. Some patches you change once a week, but the once a week patches, I find in my experience, people seldom are absorbing much when it gets to day 6 or 7. But again, it's a personal choice. Now, the patches should always be put onto a fresh area of skin, so don't reapply to the same area of skin. Allow it to breathe and settle. But it really does vary the absorption. Some of you might have known that my patches that I use don't stick on particularly well, and when I take them off after 3 days, they're often quite wrinkled, and so I know I'm not absorbing the full amount from the patch. Other people say that they stick on beautifully. It really does vary, and we know from studies that the absorption of estrogen varies according to the site by up to around 22 times. So if I put it on one area of my skin, or say on my bottom, and then the next time put it on my back where there's less fat, then the absorption might really, really vary just in between me as an individual. And that's important to know, because it might be that if you find that your symptoms are worsening and you've not changed the dose, it might be worth reflecting, have I put the patch onto a different area? Because it might be that. Or is the patch not sticking very well? Or has the skin of the body changed? And I know some people absorb the estrogen through the patches better when their skin is warmer. So they actually, some people tell me that they feel better in the summer than they do in the winter, and it might be related to the absorption through the skin, because when you're warm, your blood vessels dilate. Obviously people look more red when they're warm because their blood goes to the surface of the skin, and therefore if your blood is right on the surface, you're going to absorb it a lot easier than if you're very, very cold. Your blood vessels are constricted, they're deeper down into the skin. Estrogen isn't going to penetrate the skin in the same way. So there is a lot of variation and absorption between one person, but all of us have different skin types and temperatures and thickness and all sorts of differences in our skin. So of course what I absorb from one patch might be completely different, and often is with other people as well. So that's the estrogen part. We usually give estrogen as part of HRT. I say usually because nothing's 100% in medicine. But when we give the estrogen, you can start HRT whether you're having periods or not. So if you're perimenopausal, you'll still have periods. If you're menopausal, you won't be having periods. So you can start the estrogen, and then you need progesterone usually as well. Now progesterone we give, and I've just got a capsule here. In the UK it's called Utrogestan. There is another type of micronized progesterone available in the UK, but I've had a lot of women telling me that they are getting side effects with it, or they're getting bleeding with it, and then they go back into the Utrogestan and everything settles down. So just, it's worth, some people are fine, but if you're not, it might not be because of the estrogen part, it might be because of the progesterone part. So this is just a gel-filled capsule that people take orally, usually at night time, because it can make people feel a little bit sleepy. And there's different ways of taking it. So if you're not having periods, you don't really want your periods back, I presume. Most of us don't want to have periods. So then mostly people take it every evening. It's actually licensed for 25 out of 28 days. But usually we recommend, as do many others, that it's taken every evening. Now, if you're still having periods, initially we try and give the progesterone so you still have periods. So we say to take it for 2 out of 4 weeks, but you take 2 in the evening. Usually when people start their HRT, their estrogen, we usually say start your progesterone 2 weeks after, and then have 2 weeks on, 2 weeks off the progesterone, continue with the estrogen all the time. Some people find that they might have irregular periods, but they usually get into a routine after after a few months. Anybody who starts taking hormonal replacement therapy might get some bleeding. It's always a side effect that might occur for women, and it really, really varies between people. If people do have spotting or bleeding in the first 3 to 6 months, then usually they can be reassured and it usually settles down. But if the bleeding is troublesome, if it's heavy, if it's associated with other symptoms, or if you're concerned about it, then always get in touch with a healthcare practitioner for some advice. If the bleeding persists, that's when you should talk to a healthcare practitioner, and between us we'll decide whether the dose of hormones needs changing, whether the type needs changing, whether you're absorbing too much, too little, whether you need the dose of progesterone changing, whether you need any investigations or to be examined. So that's very individual, and I have done a whole Instagram live about bleeding, so I'm not going to go into that in detail today. So you can either take it continually, no periods, cyclically, we call it 2 out of 4 weeks. It's actually licensed for 12 out of 28 days, but we usually say 14 days because it's a lot easier to do 2 weeks on, 2 weeks off. So that's the progesterone. And then the testosterone, and I've spoken a lot about testosterone before, is a hormone that we often add after if people still have symptoms of reduced sexual desire, but also other symptoms of testosterone deficiency include low mood, reduced energy, muscle and joint pains, poor sleep, mood changes as well. And so then we give testosterone. It's either a gel or a cream. And again, I've done an Instagram live all about testosterone if you want more information. Testosterone can take a bit longer to have an effect. Estrogen and progesterone, often within 3 months, people are starting to notice whether they're feeling better or not. Some people feel better quicker than others. Again, it just depends on how the body responds to those hormones in the body. Sometimes people can get side effects initially, which can settle, and if they don't, that's when we usually assess and decide whether the dose needs altering or the type needs changing, or indeed if there's something else that's causing the symptoms as well. The other hormone to not forget are vaginal hormones, which can be given as estrogen. So there are 2 different types, usually estradiol and estradiol, which can be given as a vaginal pessary, a vaginal tablet, a vaginal ring, a silicone ring that lasts for 3 months, or there's also a cream and a gel. There's also Progesterone, which is DHEA, which converts to estrogen and testosterone. And again, I've spoken about that before. So vaginal hormones are safe whether a woman's had breast cancer or not, whether she's got anything else in her history or not, because they're very low dose and they usually only work locally, and they can be given whether a woman's taking HRT or not. But we mustn't neglect vaginal hormones, because they can be very good for localized symptoms but also for urinary tract symptoms as well. So it's just worth, if you're getting those symptoms, whether you're taking HRT or not, really think about them, whether you need vaginal hormones or not. When people are taking hormones, a lot of people have asked, how do I know I'm on the right dose? Do I need to change? I'm still getting symptoms. We often do blood tests, and they are a useful guide. We've had a paper accepted, which is great, an academic paper in a peer-reviewed journal about dosing, and that will come out soon, and I'll talk about it in a lot more detail then. And I have spoken before about dosing of hormones. But needless to say, if someone has an estradiol level done and they're on HRT and their level is low and they're still getting symptoms, then it often suggests we can increase the dose and see what the clinical response is like. Again, with testosterone, we usually do blood tests after about 3 or 4 months of testosterone and see whether people are improving or not. Some people find they don't absorb very well through if they use the testosterone cream, and we might convert them to the gel. Likewise, people might find, and I've had a lot of ladies who are on a high dose, as in 100 micrograms of estradiol patch, and their levels are just not come up at all and they feel dreadful. And so those women, I would often change to a gel. I might give them the same dose equivalent from the patch to the gel, and then they might absorb the gel better. So it's not always about changing the dose, it's often the formulation that we change as well. Important to know, I'm sure a lot of you do, that when you have estrogen through the skin, there's no risk of clot or stroke at all. Very different to the synthetic hormones, and the natural progesterone doesn't have a risk of clot or heart attack, very different to the synthetic progestogens as well. So there are lots of benefits of hormones, especially the natural hormones. People can, if they don't want to take their progesterone, or they're having heavy periods, or they want contraception because HRT is not a contraceptive, then the Mirena coil or a coil that contains progestogen can be useful. It is a synthetic progestogen, which most people tolerate very well, but you can still take the natural progesterone as well. And I have done an Instagram live about progesterone too, which I think is really useful, because the more we know about progesterone, there's some great data there out there about the role of progesterone on our brain, on our muscles, on our bone, on our cardiovascular system, on our inflammatory system as well. So it's a very important hormone that many people, including me actually, have neglected for far too many years. So lots of information. I am going to share some resources as well. We've got lots of resources. Rebecca Lewis and I have recorded for World Menopause Day, which, in case you don't know, is the 18th of October. We just recorded a podcast the other day just about basics about HRT. So I hope you're going to find that useful as well. But I've got some great podcasts coming out over the next few weeks. I've been interviewing some really inspirational people. Some of them are people with their own experience, and a lot of them are healthcare professionals as well. There's so much that we're learning all the time. I've just been writing an academic book chapter about the risks of not having hormones actually in the menopause, and that's really important to look at the biological active roles these hormones, estrogen, progesterone, testosterone, have in our body. And then it's up to us as women to choose, of course, whether we want to take them or not. But I hope you found that really useful. I hope you have a great week. I'm going to have a different week this week because it's going to be all rehearsals. So usually I'm in the clinic at least 1 day a week. So I'm going to miss seeing patients. I'm going to be in some studios, hopefully getting on all right. Looking forward to doing the first of 34 dates this Friday. So those of you that haven't done it, please can you email your photograph in, because I want to show the community of people that we have together on social media, because we're all helping each other in different ways. So it needs to be a portrait photo, just of your head and shoulders, please, and it goes to info@ and then dr for Dr. Louise Newson, all one word, so drlouisenewson.co.uk, info@ drlouisenewson.co.uk. And what I want to do is have a great montage, a great picture of everybody who's part of this community. So if you could do that, I would be very grateful. So thanks for everything. Enjoy the rest of your evening and see you. I'm not sure about next week. I want to try and do my Instagram lives, but they'll be at different times because of the tour. Obviously I can't do them this late when I'm doing a tour, but I might do some in the morning or just different times. I'm not sure, but I'll let you know. So take care, and thanks for all your support and encouragement.